I'd like to thank Dr. Maher and the rest of the staff at the Bobby Jones CSF Institute for the invitation to address you all this morning. I wish I could be here in person. That's not possible. What I'm going to talk about for the next few minutes is a new way of thinking potentially about the treatment of patients with tethered cord, and that is the posterior vertebral column subtraction osteotomy. Big mouthful, but at the end of the day, making patients shorter to remove stretch on the spinal cord. These are my disclosures and have a small bit of relevance to my remarks. When we look at blood supply to the spinal cord, and I think this intertwines very nicely with the topics today, when we look at ischemia and other things, we realize that this was a very complicated area of anatomy because of the size of the microvasculature of the spinal cord. Being able to identify this and understand how the spinal cord derived its blood flow really fell squarely on the shoulders of these two gentlemen, Cadier and Adamkowitz, who had a beautiful job of anatomically describing the blood flow to the spinal cord and really have helped inform us. And I think what we'll see as my talk progresses is that while we're talking about tethered cord, we're also talking about ischemia, and I'll give you some remarks on I think where we're going with respect to blood flow to the spinal cord, etc. So when we talk about tethered cord, obviously we're talking about stretch on the spinal cord, this inhibition of the ascent of the spinal cord during development, and this puts into play this aspect of being on stretch. Just like a piece of licorice is on stretch, the spinal cord is tethered at the bottom, and as it doesn't ascend, it is under stretch in a chronic fashion, and this stretch, I believe, is what's causing a lot of the problems and strife in these patients' lives. This is a lifelong disease process. When we talk about stretch of the spinal cord, I think it bears a small pause. Historically, this is Alpha Brigg. Alpha Brigg was a neurosurgeon from Sweden, and he came to believe that the stretch of the spinal cord could be potentially responsible for multiple sclerosis and a variety of other neurologic diseases. While he may have been off target there, he did very eloquently describe the fact that stretch can cause problems and that tension of the spinal cord is a pathologic situation. And these are some beautiful studies that he did, when he would take cadavers and put them in flexion and extension. And you see on the left here in flexion, the fibers of the spinal cord are on stretch and are lined up beautifully, and then in extension, things relax. And this has to do a lot with, I believe, what is happening in tethered cord syndrome when we have a chronic stretch situation. This also is, prevailing theory in sports. When we talk about football players and spinal cord injury, for instance, majority of injuries occur when the neck is flexed and those fibers are under flexion and they're stretched, and it probably leads to a higher rate of injury to the nervous system, as opposed to extension. So when we talk about tethered cord syndrome, we realize that this is a constellation of neurologic symptoms. We talk about the thickened filum terminale and lipomyelomyingocele, but at the end of the day, the spinal cord doesn't descend and it's on stretch. And the pain and symptoms that these patients get is disabling, and it really is a lifelong sentence with this disease process. Severe pain, lower extremity pain, and then of course weakness, numbness, and bowel bladder dysfunction. And the presentation obviously is different in the two categories. We're all familiar with the presentation in children. In adults, it's a little bit different. Even a trivial trauma can set some of these patients off, and I have patients who had been doing well until just a ground level fall, and I believe what happens is that we get an acute stretch of the spinal cord, which really unleashes a cadre of symptoms. And again, this all has to do with being on stretch and the tension that's applied in the normal human with flexion, but in the tethered cord patient, I would say that they're on stretch all the time. Yoki Yamada looked at this and did a beautiful job of demonstrating the tensile properties of the spinal cord, where he would actually pull on the spinal cord in a rat, and we could show basically that there are changes in blood flow, hypoxic changes to the spinal cord, and then ultimately a loss of electrophysiologic conductivity. It's a vital structure. It is an organ, and again, it doesn't like to be stretched, and it doesn't like to be stretched chronically either in the setting of tethered cord. We wrote about this a number of years ago in Phoenix, again looking at the main factors, and it was really probably a reduction in blood flow and an impairment in oxidative metabolism that was most responsible for these symptoms. What do we have available to us now really is the detethering operation. And this is an operation that's been around obviously for a long time. And the goal of this is to loosen up scar tissue, to take down these adhesions, and to, while we would love to have an ascent to the spinal cord, that doesn't really happen. But when we loosen up the scar tissue, patients get better. If you look at it long term, though, a lot of these patients don't get better for a long period of time. And when we look at Kaplan-Meier curves, patients get better for a period of time, they get worse. They have a second, a third, fourth, fifth, and sometimes even more detethering operations. But as you can see here, the spinal cord is still plastered at the bottom, and as careful as we are, there's recurrent scar tissue, and these patients in the long run don't usually have a durable result in their detethering. So really the question comes is there a way to go about this in a different fashion? Can we take that tension off the spinal cord without going from below, without taking and releasing that scar tissue, but actually taking away a vertebral body? We do this at the level of T12. I'll go over why that's the case, but ultimately are able to shorten the vertebral column and take the stretch off the spinal cord. Advantages of this procedure, obviously, that there are no direct manipulation of nervous structures. We don't get into the intradural space. We don't have CSF leak. And hopefully and potentially this could be a more durable solution because, again, physiologically, we are definitely taking away that stretch from the spinal cord. The disadvantages, of course, are that this is a large operation and there's a risk of adjacent level disease, etc. Not for the faint of heart doing a spondylectomy of T12. When you looked early on and Coco Bun's series, and he was the neurosurgeon from Japan who really trademarked this procedure, the fact of the matter is that there was a significant improvement in patients in his early series, which really got me thinking about whether or not we could be doing this on a more regular basis. And in his series, again, there were 8 patients. T12 was selected because that's at the level of the last dentate ligament. If you do this operation and take away a vertebral body in the mid-thoracic spine, for instance, because of the dentate ligaments, you're not going to enjoy and appreciate that lack of tension on the spinal cord. So this needs to be done at the level of T12 or below. Once we start getting the lumbar spine, spondylectomy becomes a much more challenging operation. That's why, for a number of reasons in spinal balance, T12 is really the ideal level. So I went to the lab, and these studies were done in Phoenix, where I wanted to understand exactly what was happening as we take away and do a spondylectomy and osteotomy of T12, and what's happening to the neural elements. So we looked at this, and what we found was the dentate ligaments were critical in stabilizing the spine. So T12 and below is really where you want it to be able to take the tension off the spinal cord. And as we do this, literally the patient becomes completely disconnected, and the only thing holding them together is the spinal cord. And for this reason, we put temporary rods in. I do this with 2 attending surgeons, and this is an operation that has to be done under very controlled circumstances. And again, as we take that, we aim for somewhere between 20 and 24 millimeters of shortening to be able to take the tension off the spinal cord and then put in apposition the bone so that we get healing, so that we don't have a failure of our hardware. And again, this is showing the vertebral column after it's been shortened in a cadaveric specimen. And we did CT myelography in these cadavers as well, and we wanted to understand what happens to the spinal cord. And one of the things that happens is, of course, we get some buckling of the spinal cord as we continue to increase the reductions at 22, 27 millimeters. We'll get this kinking of the spinal cord. The problem with that is that too much kinking can actually cause a problem in blood supply to the spinal cord, which could actually lead to spinal cord injury. So we do these with electrophysiologic monitoring, both motor and sensory potentials, and also the ultrasound to understand what's happening to the spinal cord and the vasculature at the time of surgery. This is our series of 20 patients that really was the culmination of about 10 years of work and long-term follow-up with these patients, both in Phoenix and in Baltimore. Now we have closer to 30 patients that we've done. And, to show you and take you through the procedure, again, T12 is the target end level. It's a neutral segment of the spine below the last dentate ligament. And as we take away T12, we aim to shorten the patient by about 20 to 24 millimeters to indirectly take that tension off the spinal cord like a piece of licorice on stretch to decrease that amount of stretch. And again, once we're planning on doing this, hardware is placed with image guidance and now with robotics. And being able to shorten this patient reliably, we can do very reproducibly, but again, with temporary rods and with clean care, because once the osteotomy is done, this is 2 patients, so you must have a temporary rod in. And again, you have to do this under the most controlled circumstances. This is operative footage showing again placement of the screws with guidance. We're now using robotics. Wide laminectomies of T11, T12, and L1 to allow the spinal cord to drift posteriorly and to prevent kinking if you just did a laminectomy only at T12. After the hardware is placed, we use the bone scalpel to be able to make beautiful cuts, performing the laminectomy and also being able to do the facetectomies and expose the dura. Once this is done, we're taking a section of the rib out, so this is a costotransversectomy also at T12, and then going down the pedicle to be able to perform a T11-12 discectomy and then remove the majority of T12, probably 70 or 80%. Again, we do this with measurements that we make preoperatively and then utilizing image guidance to show us where we are in front, at the front of the vertebral body, all the way up to the anterior longitudinal ligament. Obviously avoiding structures beyond like the aorta, and then of course with a temporary rod, as we make these cuts with osteotomes in the bone scalpel, literally being able to, when all is said and done, place devices in so that we can reliably, under direct vision with ultrasound, shorten the patient. And it's really a beautiful operation. And from a physiologic standpoint, it is a big operation. Some of these patients are morbidly obese with terrible problems. So it's, again, great care to attending surgeons. So we look at ultrasound, and this is just to show you something which I think is compelling. And if we look on the left here, this is pre-shortening. We see in an axial view some minimal excursion. The spinal cord is relatively tethered. But look what happens on the right after we shorten this patient. Look at the excursion and pulsations of the spinal cord. This really got me looking at exactly what happens. But that spinal cord is no longer on significant tension. We relaxed that, and the spinal cord appears much happier in its pulsations, which normally occur with heartbeat. Patient has small pedicles, and you can see here incredibly small pedicles, but with image guidance and robotics, we're able to cannulate those pedicles and ultimately get the desired result of shortening them by about 20 to 22 millimeters with bone-on-bone apposition and excellent chance for healing and hopefully decreasing our chances for deformity. When we look at our series, again, and we'll show you this in more detail, but the patients are all over the place. This is a lifelong process. These patients are unhappy. They have significant symptoms over a long period of time. Pain by far and away is what brings them in to see us, and then disability with motor and sensory changes and bowel and bladder deficits. When we look at how we do with this and we look at the symptom improvement, pain gets better in the majority of these patients, back and leg pain, and we have significant improvement in sensory, motor, and even urinary dysfunction. So it really is a beautiful thing, and we have now long-term follow-up on these patients. When we look at the Oswestry Disability Index, statistically significant improvement in disability in these patients, durable over the course of years in some of our earliest patients. And we see these numbers drop over time. And this really was eye-opening as we start plotting this out and following these patients, because once you as is often said, nothing kills a study like long-term follow-up, but the reality is that these patients continue to do well over time. And when we look at the outcome in our series, 88% improvement in back pain, 50% greater improvement in incontinence, 80% in motor, and 80% in sensory. Really very powerful results for this procedure. Certainly the literature is all over the place with series, but this was the largest series prospectively, retrospective data collection of a series of patients who we have done over the past 10 years. And again, height reduction, not to belabor the point, but aiming for between 20 and 24 millimeters, 22 is probably a great number. Complications do occur. We had an infection. One patient had a cap of a screw that popped off. We needed to take them back to surgery. One patient's a new sensory dysfunction, which actually got better. Thankfully, no lasting problems in any of these patients. What's really beautiful to see are the radiologic results, and what we see actually is an increase in caliber of the spinal cord. We see in the axial plane, the spinal cord get thicker as we shorten the patient. So this is beautiful. So it shows us physiologically that we're doing something. We see in the sagittal plane that there's less bowstringing of the spinal cord where it's normally taut, and it seems relaxed. That distance changes behind the vertebral body. And ultimately, these have been characterized over a number of patients, but really helping us understand exactly what we're doing and proving visually, not just with ultrasound, but also with MRI scan, that we're improving the morphology and tension on the spinal cord. No doubt that that's happening.
I remember these days in high school where I would literally be crying in class just because I was in so much pain, and there was nothing that could mask that pain. There wasn't strong enough medication for it.
So this is a now 21-year-old young woman who I operated on 2 years ago, who was really in extremis. She was in nursing school and pretty much unable to function, had had 6 prior tethering operations, and after a long discussion decided to proceed with vertebral column resectioning at T12. And utilizing robotics, she had very small pedicles. She was the case I showed you. We were able to do a very nice job of shortening the vertebral column, and she's done incredibly well, as many of these patients have.
Every time I went in, like, hey, Dr. Theodore, I want to get a mom. Almost became like a challenge to get, what can I do and what's the next time? Good evening, Ruth. I'm studying for finals.
I love hearing the envelope in the question in her case. I love hearing about her successes. So I wish she had told me about the skydiving before. Thankfully, she's doing great. I was actually pregnant and expecting the birth of her first child here in the next couple of weeks. But being able to impact patients with this type of problem, not everybody does as well as this young woman. But the reality is, I think this has opened my eyes to a new way of potentially treating this problem. And I think that now, and Andrew J. Who is now in Oklahoma, has published a series of 40 pediatric patients. I think what we're going to see is that this is a potentially powerful alternative to detethering as we know it. And hopefully we'll have further results to share with you as time goes on. I'll let you decide who had the shortening operation in this slide. I'd like to pivot just for the last few minutes and talk about spinal cord blood flow, because stretch has everything to do with impairment of blood flow, and other things are happening physiologically. So I had a significant interest in looking at the blood supply to the spinal cord, not just in tethered cord, but in trauma. And we know that the spinal cord has autoregulation just like the brain does. And when we decrease blood flow to the spinal cord, we faint in humans. We can have infarction in humans, in adults, I should say, or in patients with spinal cord injury. Again, this spinal cord blood flow is the same idea. looking at intrathecal pressure and mean arterial pressure to get a spinal cord perfusion pressure. And we understand too that there's a differential between gray and white matter. The gray matter is affected more, deep structures, higher oxygen concentration requirement. And the reality is that the same things apply, but understanding this, I think, is important, because as we take that stretch away from the spinal cord, I think we are improving blood flow. So in trauma, we talk about increasing perfusion pressure acutely to perfuse the spinal cord. And this is something I have become very interested in. Not a lot of data, really it's class 3 data, but we know empirically, based on animal studies as well, that low blood pressure after trauma is deleterious. Spinal cord function is impaired further. So we want to keep that mean arterial pressure elevated. We want to prevent patients from becoming hypotensive. And interestingly, the same tenets apply in the brain as they do in the spinal cord, that we want to perfuse the spinal cord. And ultimately, the concept of spinal cord perfusion pressure is what we should probably be looking at. And again, this is very interesting, because maintaining that also gives us the opportunity to do something different. And one of the things that we think about differently is draining spinal fluid. And how do we do that? Well, we through a lumbar drain, but the spinal cord perfusion pressure, just like with a ventriculostomy, where we can drain spinal fluid to improve CPP, we can improve spinal cord perfusion pressure in the same fashion. And I became interested in this when we looked at the results of AAA repair and abdominal aortic aneurysm, and we realized that about 40% of those patients early on were becoming paralyzed, and the Glasgow surgeons did everything they could to ameliorate that number. And one of the things they did was to drain spinal fluid. And I became very interested in this, and there have been multiple studies done in dogs. We replicated this in rabbits and also in pigs. And in a pig model, which was very instructive for me, what we found out was that in acute trauma, the blood flow changes. I'm going to show you that data right here. And this is really the summation of several years of study. And that is simply this, that after acute spinal cord injury, we have a decrease in these numbers. The y-axis is perfusion of the spinal cord. So after spinal cord injury, perfusion drops. Autoregulation is lost. When we increase the mean arterial pressure, which is the red line, the perfusion improves for a while. And what happens then is spinal fluid pressure increases, and then the perfusion decreases. But guess what? If you increase mean arterial pressure and drain spinal fluid, you have maintained perfusion over the course of time. So this opened my eyes to the reality that we probably should be looking at spinal cord perfusion pressure. And we took this to the clinic. We got funded by DOD, and unfortunately, we're only able to enroll 11 patients. No adverse outcomes, but a trend towards some improvement in the patients that had spinal fluid drained. When you talk about spinal fluid in general, we can go backwards in time too and look at something like the zebrafish. And there's a beautiful model that was done where they took out the ependymal cells in the zebrafish, so the lining of the spinal cord, which basically decreased pulsations of spinal fluid. Once that happened, these zebrafish developed scoliosis, and again got me thinking whether this flow of cerebrospinal fluid could also be a problem in idiopathic scoliosis in children. And also, in an acute phase of treating somebody with either tethered cord or spinal cord injury, should we be looking at perfusion pressure and measuring spinal cord blood flow? So we're not really able to do that in real time, but this year I was funded by DARPA and for a large project looking at the perfusion of the spinal cord and developing next generation monitoring devices. And hopefully soon we'll have a device where we can actually look at these patients across the spectrum with biomarkers in the blood and CSF to look at ischemia in the spinal cord, and then ultimately in real time look at blood flow in the spinal cord. So we're developing micro devices which can be placed on the dura to measure spinal cord blood flow in real time that can be removed, that will inform us on how we're doing after surgery, whether it's for tethered cord or scoliosis or even trauma, obviously, which was our primary concern. being able to measure blood flow in real time, again, it's not possible in the spinal cord, but we're very close to developing these devices, which we will be able to implant in man to inform us on treatment paradigms for not just acute injury, but even for surgeries to prevent ischemia to the spinal cord. The pictures that we're getting are unbelievable. The data that we're generating now, looking at real microvasculature of the spinal cord, are unprecedented. And I hope to share with you in the upcoming years early data on our trauma model and ultimately potentially a model for tethered cord as well. Putting these all together in the treatment paradigm of draining spinal fluid and maintaining perfusion pressure, starting with trauma, but also then transcending both into tumor deformity work, and also for problems like tethered cord, where we want to make sure that the spinal cord is perfused and healthy as we do these operations. So ultimately, I think that there are many new potential strategies coming out for adult tethered cord, and I think the vertebral column shortening is going to become a powerful adjunct in our armamentarium to treat these patients across the spectrum of their disease. Ultimately, starting out with the detethering operation, if it fails once or twice, rather than repeating it, considering something different like a vertebral column resection, but continuing to follow these patients over time, because I don't think we're going to be able to compare them head to head against our detethering operation. But what I see is continuing to follow these patients long term, and potentially establishing a new way to treat patients with tethered cord, spinal cord injury, and other spinal cord dysfunction. So again, Cormac, thank you very much for the ability to address you today, and thank everybody for their time and attention. Have a great day.